If you are over 50 and your mind feels foggy, stop scrolling for 8 seconds. One common night medicine can mimic early memory decline, and most people never suspect it. Dementia can touch any family, and the earliest signs are often quiet. Misplaced keys, a familiar word that will not come, a name you know but cannot pull up. Many people assume this is just aging. But there is another possibility worth discussing with your doctor: your medication list. Here's the rule most seniors never hear. It is rarely one pill. It is the stacking effect. When several medicines share similar brain side effects, the burden adds up over time. That can create brain fog that looks like normal aging. Important safety note: this video is not telling you to stop any prescription. Some of these medicines are necessary and helpful. The goal is awareness and a safer conversation with your clinician or pharmacist. In the next minutes, I will walk you through 9 medication categories that geriatric guidelines often flag for possible cognitive side effects. I will rank them from the most overlooked to the most important to review. Stay to the end because I will give you a simple checklist of questions to ask at your next medication review. Now, number 9. This one is hidden because it is not a prescription. Diphenhydramine, commonly known as Benadryl, appears in many allergy, cold, and nighttime sleep products. Because it is over the counter, it feels harmless. But diphenhydramine is anticholinergic, meaning it can block acetylcholine, a brain messenger involved in attention and new memory formation. In older adults, that can show up as next-day grogginess, slower thinking, and short-term recall problems. This does not prove it causes dementia, but it is a strong reason to review frequent use. What to do instead? Read labels for diphenhydramine, ask about newer non-drowsy allergy options, and safer sleep strategies. And if sleep is the issue, look at the root cause: pain, reflux, anxiety, or caffeine timing before you rely on a sedating pill. Now let us move to number 8, a medicine millions take daily for heartburn. Before we go to number 8, you need one simple framework, or the entire list will feel random. This is not about one brand. It is about one brain pathway that keeps getting hit from different angles: acetylcholine. Acetylcholine is a messenger your brain uses for focus, learning, and forming new memories. It helps you stay on track in a conversation. It helps you store what you just read. It helps you remember why you walked into the room. As we get older, that system can become less efficient for many reasons, including sleep quality, stress, and normal age-related changes. So when a medication blocks acetylcholine, the effect can feel stronger than it would at age 30. Here is the pattern most people miss. Some medications can create symptoms that look like aging even when the root issue is medication effect. The signs usually start small: slower recall, more trouble multitasking, feeling mentally dull in the morning, needing longer to find the right word. Family may say you seem distracted. You may blame stress or poor sleep. But if these changes line up with a new pill, a higher dose, or a new combination, that timing is a clue worth reviewing. Now for the big warning. It is rarely one pill. Many common medicines carry some anticholinergic activity. Sleep and allergy aids are the obvious ones, but bladder medicines and certain antidepressants can add to the same burden. When several stack together, brain fog can rise quietly. Quick check-in. If you have ever felt that slow fog after a medication change, comment FOG below. One word, no details. Now, let us continue the countdown. Number 8 is a category used by millions, and the issue is often long-term use without reevaluation. Proton pump inhibitors, or PPIs, are common for heartburn and reflux. You may know Prilosec or Nexium. For short-term relief, they can be very effective. The concern starts when a short-term solution becomes a long-term habit, especially in older adults. PPIs lower stomach acid. That can reduce burning, but stomach acid also supports digestion and the absorption of certain nutrients. Over time, some people develop low vitamin B12, low magnesium, or low calcium while on long-term acid suppression. Those issues can affect the nervous system and may show up as fatigue, tingling, mood changes, slower thinking, or memory slips. In real life, that can look like early cognitive decline even when the driver is nutrient status, poor sleep from reflux, or overall medication burden. Important safety point: do not stop a PPI suddenly on your own. Rebound acid can hit hard and symptoms can worsen. Instead, talk with your clinician about whether you still need daily therapy, whether the dose can be reduced, whether a step-down approach to an H2 blocker is appropriate, and whether checking B12 or magnesium makes sense for you. Also look at triggers. Smaller late meals, earlier dinner, less alcohol, and less caffeine can help some people. Now let us move to number 7, a bladder medication that connects directly back to acetylcholine. Next is number 7, and this one catches people off guard because it is prescribed for a very real quality of life problem. Overactive bladder can steal your sleep, your confidence, and your ability to leave the house without planning every bathroom stop. That is why medications like oxybutynin can feel like a rescue. But here is the twist. Oxybutynin often shows up in medication reviews for older adults because it can affect the same brain system we have been talking about. It belongs to a group called anticholinergics, meaning it can block acetylcholine. And acetylcholine is not just a memory chemical. It supports attention, processing speed, and the ability to track what is happening in the moment. This is why the cognitive effect can feel confusing. You are taking a bladder pill, not a brain pill. Yet some people notice changes that sound like aging, missing an appointment you would normally remember, misplacing items more often, losing the thread of a conversation when there is background noise, waking up with a heavy mental haze. None of these symptoms prove a medication is the cause, but the timing matters. If they started after a new prescription or a dose increase, that deserves a closer look. Here is the pattern interrupt. The goal is not to suffer in silence. The goal is not to quit the medication on your own. The goal is to review options safely. The safest move is a structured conversation with your clinician or pharmacist. Ask 2 direct questions. Does this medication have anticholinergic effects? And is there an option with a lower cognitive burden for someone my age? In some cases, different therapies such as mirabegron may be considered because they work through another pathway. Non-drug strategies can also help, like pelvic floor training, bladder scheduling, and fluid timing earlier in the day. If you have ever taken a bladder medicine for urgency, comment bladder below, 1 word only, no details. It helps me know how common this is in the audience. Now we move to number 6, a category tied to heart health that many seniors take for years. Statins are used to lower LDL cholesterol and reduce the risk of heart attack and stroke. For many people, they are a clear net benefit. So this section is about balance, not blame. Here is the key idea. Cholesterol is not only a cardiovascular marker. The brain uses cholesterol to build cell membranes and support myelin, the protective coating around nerves that helps signals travel efficiently. That does not mean lowering cholesterol harms the brain for most people. Research on statins and cognition is mixed. Many studies show no meaningful cognitive decline for typical users. But a smaller group reports brain fog or short-term memory changes, often after starting a statin or moving to a higher dose. What does that look like? Forgetting names you usually remember, losing your train of thought mid-sentence, taking the wrong turn on a familiar route, struggling to recall a recent conversation. Again, none of these symptoms prove the statin is the cause. Sleep deprivation, depression, thyroid issues, vitamin deficiencies, and other medications can produce the same symptoms, but timing matters. If the change started after a medication change, that is a useful clue. Important safety note, do not stop a statin on your own. Stopping suddenly can increase cardiovascular risk. Instead, bring a simple timeline to your doctor. When did you start? When did the dose change? When did the symptoms begin? In some cases, a lower dose, a different statin, or a different plan may be considered based on your overall risk profile. Now we reach number 5, the anxiety and sleep medications that can calm the mind fast but slow the brain over time if used long-term. Benzodiazepines include medicines such as lorazepam, diazepam, and alprazolam. They work by enhancing GABA, the brain's main calming signal. At first, that relief can feel like a lifesaver. The mind quiets down, sleep comes faster, the body loosens. The concern is what can happen with ongoing use, especially in older adults. When a medication regularly turns down brain activity, it can also turn down alertness, reaction time, and learning speed. Over time, some people describe a persistent fog, slower thinking, reduced emotional range, or a feeling of being disconnected in conversations. This is not weakness. It is a predictable effect of a sedating medication in a brain that may be more sensitive with age. Another issue is dependence. The brain adapts. The same dose can feel weaker, and stopping suddenly can cause rebound anxiety, severe insomnia, and withdrawal symptoms. That is why the safest rule is simple. Never quit benzodiazepines abruptly without medical guidance. If you and your clinician decide it is time to reduce or stop, the standard approach is a slow taper matched to your situation. In parallel, many people improve when they treat the root cause of insomnia or anxiety. Cognitive behavioral therapy for insomnia, breathing training, sleep routine changes, and addressing pain or reflux can reduce reliance on sedation. Now let us move to number 4, an older antidepressant still used for sleep and nerve pain, and it connects directly back to the acetylcholine pathway. Now we move to number 4, and this is where many people get fooled. Because the pill may be helping you sleep or calming nerve pain, you assume it is harmless to the mind, but in older adults, the trade-off can be quieter and more costly. Amitriptyline is an older antidepressant still prescribed for chronic nerve pain, migraine prevention, and insomnia. It can feel like a familiar, trusted option because it has been used for decades. And for some patients, it genuinely helps. The issue is that in seniors, amitriptyline is also one of the medications clinicians often review carefully because it can carry strong anticholinergic effects. In plain terms, it can interfere with acetylcholine, the brain messenger we discussed earlier that supports attention and new memory formation. When that system is already less efficient with age, blocking it can lead to symptoms that look like cognitive decline. Not dramatic collapse, not a sudden crisis, more like a slow dimming. Here is what makes it tricky. The change can be gradual and easy to explain away. You feel a little less sharp in the morning. You need longer to find words. You forget what you were about to do. You lose the thread of a fast conversation. Family members may assume it is normal aging, especially if the medication is improving sleep or reducing pain. But if the trade-off is persistent brain fog, it deserves a review. Important medical honesty. Not everyone will notice these effects, and taking amitriptyline does not mean you will develop dementia. Research in this area often shows associations related to long-term exposure and overall anticholinergic burden, not certainty for any one individual. The goal is not fear. The goal is informed choices. So what is the safest move? Do not stop the medication suddenly. Instead, ask your clinician or pharmacist 2 direct questions. Does this medication have anticholinergic effects? And are there alternatives with a lower anticholinergic burden for my specific problem? Depending on your condition, that might include different pain strategies, newer medication options, or non-drug sleep approaches that reduce reliance on sedation. Quick check-in. If you have ever taken a medication mainly for sleep, even if it was prescribed for something else, comment sleep below. 1 word only, no details. Now we move to number 3. And this one surprises people because it sits in a category many assume is always gentle, SSRIs. Paroxetine, often known by the brand name Paxil, is an SSRI used for depression and anxiety. SSRIs as a group are often viewed as safer than older antidepressants for many patients. But paroxetine is frequently discussed differently in older adults because it can have more anticholinergic activity than several other SSRIs. That matters because anticholinergic effects can interfere with acetylcholine and show up as brain fog, weaker short-term recall, and reduced attention in some seniors. This does not mean the medication is bad. It does not mean it causes dementia. It means that when cognition changes, paroxetine is one of the first SSRIs clinicians consider reviewing, especially if the dose increased or the medication was added on top of other anticholinergic drugs. You may also hear clinicians mention the Beers criteria. It is a set of guidelines used to flag medications that may carry higher risk in older adults. Being listed does not automatically mean the drug is wrong for you. It means it should trigger a careful risk-benefit conversation. If you are taking paroxetine and you have noticed memory slips, the safe move is not to quit. Stopping antidepressants suddenly can cause withdrawal symptoms and a return of anxiety or depression. The safe move is to talk with your prescriber about whether another SSRI or a different approach could fit your needs with fewer cognitive side effects. Now we are down to number 2 and number 1. And this is where the biggest lesson of the entire list becomes clear. Now let us move to number 2 and number 1, because this is where the entire countdown clicks into place. If you remember nothing else, remember this. Fast decline is often not a mystery. It is often a medication moment that deserves immediate review. Number 2 is antipsychotic medications. These are powerful drugs that can be appropriate for specific psychiatric conditions, and in some situations they are used to manage severe agitation or dangerous behavioral symptoms. But in older adults, they are also sometimes used off-label for sleep, restlessness, or behavior issues, especially in care settings. That is why clinicians treat them with caution. Here's the practical concern. In seniors, antipsychotics can increase sedation and raise fall risk. They can also affect movement, blood pressure, and overall alertness. In certain older populations, they may be associated with serious complications, which is why they come with strong warnings. They can also influence dopamine pathways that affect motivation, processing speed, and mental clarity. So if a loved one seems to change quickly after starting one, it does not prove the medication is the cause. But it is a red flag that deserves an urgent professional review, not a wait-and-see approach. Now, number 1, the most overlooked risk is not one pill. It is stacking. Medication burden. This is where the acetylcholine story returns. When multiple medications with anticholinergic or sedating effects pile up, the total burden can rise quietly. 1 pill for sleep, 1 for allergies, 1 for bladder urgency, 1 for mood, another for reflux. Each one may be reasonable by itself, but together they can create a fog that looks like aging, depression, or even early dementia. Not because you are failing, because your system is overloaded. Here is the fix that actually gives you control. Do not panic. Do not stop medications on your own. Do one high-value step. Schedule a structured medication review with your clinician or pharmacist. Bring everything: prescriptions, over-the-counter products, supplements, and especially nighttime sleep aids. Then ask 3 questions. First, what is still necessary right now and why? Second, what can be reduced, simplified, or replaced safely? Third, which items have anticholinergic or sedating effects and what is the total burden? This is the real takeaway. Protecting your mind is often less about adding one more thing and more about removing hidden friction. If you want a simple checklist for that medication review, comment "review" below. 1 word only. And if you know someone over 50 who keeps saying, "I feel foggy lately," share this video with them. Because the safest first step is not guessing. It is a better conversation.